Hello and welcome everyone to tonight's EAO Just Ask show, your monthly appointment with one of the leading experts in this field. And tonight it's just an enormous pleasure for me to host this show together with a very old friend of mine. He's not only a friend of mine, I think we share two things in common. The first thing is we're both Germans. That means we were really on time for tonight's show. And the second thing, we both attended New York University at a certain point in time. Tonight, it's a great pleasure to welcome Peter Gehrke. Peter, welcome to the show.
Hello, Stefan. Hello, everybody outside there.
Peter, I think you're very, very world famous, known for your expertise, in particular when it comes to superstructures and also which materials are we using in the aesthetic zone, but also in the functional zone. So we are really eager to get your knowledge in that field, because I am more a little bit the surgeon. And to be honest, some years ago, I thought, well, I mean, the most important thing is that the screw is in the bone and the soft tissue is perfect. Today, I would say, I think it's maybe even more important that the superstructure is perfect, it's cleansable, it's biocompatible. And that's why we have you here tonight. I don't think I need to really introduce you. You study dentistry in Germany. You work for the industry, for the implant industry. You attended New York University for postgrad program. You work in an office in the middle western part of Germany, I'd say. You did your scientific career at the University of Frankfurt. You have your PhD there. Yeah, you work on scientific projects, but you're also well known as a clinician. So I think you're the true expert, and we already have a lot of people logging in here. So people coming from Albania, people coming from Syria, Peter, with people from Spain and Romania, so all over the world. So again, welcome, and it's my great pleasure to have you here.
The pleasure is just with me joining you with the Just Ask session. I'm very happy to be with you.
Peter, today I inserted a final restoration, and I thought a little bit that I have this meeting tonight with you, and I want to show you a picture because you're the expert. And I thought, oh, would Peter do the same thing? Would he do something different? Just as a quick introduction, so this is a titanium base. It's a monolithic zirconia superstructure, which is glazed from the top of the supragingival area. So Peter, just give me 2 sentences. Was I wrong, or was I right, or was I in between?
No, you were absolutely right. So when it comes to the clinical use of tie-base abutments, which we see in the picture here from Stefan, this is probably the one abutment structure for the anterior, but for the posterior, which most of us are using right now, so that we actually glue 2 things together. You know, the ceramic, this is a monolithic thing, mostly monolithic because we won't encounter any cracking or chipping of the ceramic anymore. And then we have a very stable connection to the implant. So, Stefan, this is actually what a lot of us are doing right now. So I think this is very common and makes sense. But I'm happy that you're asking this question, because I would say 15 years ago, nobody would even care about the abutment, because we all did use standard titanium abutment, stock abutment. So obviously we are in a different aspect and timeline now of implant dentistry.
And we didn't give this emphasis, right, on the prosthetic superstructure. I mean, we thought, I mean, it's just an impression, and the lab technician should put something on top of it. But the most important thing is the screw, but it's not. And that is what we want to learn from you tonight. And without further delay, we want to get your knowledge. You have prepared a very small lecture for us, yeah, we thought we're going to make it a little bit interactive. I'm hoping that the surgeon, me, is asking some stupid questions in between. So Peter, just give me a very friendly answer if it's really a stupid question. With this, please, we're looking forward to your presentation.
I'm very open to any question which arises during this little talk. See, and I'm again happy that you asked this question of your abutment, because when we look of what we are doing, you know, I'm a restorative doctor, I'm a prosthodontist, and I always ask myself, why do we do it so complicated when we are talking about implant prosthodontics? For me, you know, isn't it the same doing a crown on a tooth? We're dealing with gingiva, or are we really restoring an implant with an abutment, and then we have peri-implant mucosa? And what I have learned on the hard way is really that these two restorative aspects in prosto, they are alike, but they are not the same. And maybe this is the basic theme today, that we are looking, what are the differences in there? As we all know that with peri-implant mucosa, there is a lack of connective tissue fibers. It's hypovascular, it's basically scar tissue. But we as dentists, we would like that this looks like healthy gingiva. And because it's non-vascular, sometimes that's difficult. So according to me, we are taking advantage of the beneficial aspects. That means for these patient cases like this is a very young lady. Obviously, she has anodontia, so multiple missing teeth in the anterior and posterior of the maxilla and mandible. And the function part of that, that means the implant, but then the abutment and the restoration. We are taking advantage with implants of that. But aesthetics is a major concern, and it's getting more and more of our patients, because they would like to have beautiful teeth. And the question comes up, what is the appropriate abutment and superstructure when we are talking about single or multiple implant restorations in there? And if we're looking closer on that, this is what Stefan just said. Okay, what do you think about a tie-based abutment? Again, still golden standard or titanium standard today would be a stock abutment. Commercially available abutment, you know, corresponding to the implant system we are using, and with the circumstances, with the individual anatomical environment, this is an example where we see the selection of standard abutments. They did not have to be prepared too much. And then we can have, in some of the instances, beautiful outcome of there. If you look at the soft tissue biotype of there, this is thick. You see that the emergence profile is wonderful. So we can have good results with a long-term follow-up for this patient, for example, after 8 years. So the question arises.
Peter, I have a quick question. I mean, this is obviously like 10 years ago, and you use stock abutments. Would you do it different today?
I would probably do it differently, because I would look for a more individual, customized implant abutment.
Although it's coming out very, very tiny
nicely
and slim also, which you would probably also duplicate a little bit, right?
Yeah, you know, this is an example where it came out nicely, but if you look at the retention capacity, it's a very thin abutment. And it's once in a while we are losing retention, so decementation of these abutments or restorations on the abutment. And we sometimes see decementation, and that's a technical problem in the office. So, and this is one case of many, many cases where this kind of abutments would not be appropriate in there. So therefore, yes, there are cases like this. And in these cases, I like to keep it simple, you know, not on purpose, make it complicated, but not all cases can be treated like this. I would rather say that the abutment and restoration should be as individual as the fingerprint for each and every case we are looking at. So selecting the right abutment in combination with a restoration time. So you have talked about that. We are talking about functional aspects as well. Although today we are looking at the aesthetic region, and there's the same issue. If you're using stock abutments like the left one showing, most of them have to be additionally prepared. They have to be grinded in the laboratory. And then sometimes there is a very small stick, and we put big crowns on them. This is the retention issue. We have no influence on the mucosa outline or the cementing outline if we need to cement of the shoulder. So that basically shows that the issue, the job is if I have the choice between stock and customized abutment, I would rather go for customized in those cases where I have some concerns. And if we look at the options today, and this is different of 15 years ago, where we had one option of stock abutments of the catalog of each implant manufacturer, today we are distinguishing one piece individual anatomic CAD/CAM abutments. These are the first three. You see full zirconia one piece, titanium, of course, and you see the golden colored, which is not gold. This is titanium nitride. There are others available in more pink, very thin layer. And then we see what you just did, Stefan, the tie-base abutment. So either monolithic, as to the far right, which are fully grinded and occlusally screw-retained, or you have just the mesostructure, the coping being glued and cemented on a tie base, and you cement a crown on top. These are the options, and that shows us that we have much more options today available, and not to forget that we can have, in a cut-back instance, one implant crown being luted to a tie base in the aesthetic relevant area, still on tie base, and this is orally screw retained. That means these kind of restoration in the aesthetic area are combining all the benefits for me. I have a screw retained restoration in case I need access to the implant. I do have a cut back full ceramic, for example, zirconia, and then I aesthetically veneer. One concern of tie-base abutments still today is retention, as I said. So we have described the luting protocol, that you need grit blasting, for example, of 50 microns for at least 20 seconds to prepare the material, that you need a standardized protocol. You cannot just use any kind of implant cement. And then we are very much concerned of the emergence profile and the soft tissue health, because we would like to have it look nicely, beautiful, but of course it has to be healthy, as functional as everything around. And then the question comes up, and I understand your question a little bit about that, not only the quality of your treatment as a dentist, the quality of what we are using, which is produced either by the manufacturer or in the laboratory. And just to understand for everybody, aesthetics is important, but it still has to be functionally, and that has to be combined for a long-term success. So by coincidence, more than 10 years ago, we did a study where we looked at the surfaces of different ceramic abutment, because one-piece ceramic abutments have not been an option from now on, because it's such a strong material that we see grinding within the internal connection of the implant. So we are not using one-piece zirconia abutments anymore, although we liked the non-discoloration. There were no color shifts. But what I would like to allude to is that if you look at this early study, you see we still have the option of lap side fabrication as tie-base abutments. So they are all tie-base abutments, either from your local laboratory as A and B, and then you see manufactured C, D, E, and F. They are all ceramic abutments, CAD/CAM, anatomic, patient individual abutments available. And I thought up to that study, they might all be the same, because they are CAD/CAM derived. That has to be, by nature, more accurate, so they are all the same. And if you very closely look at the emergence and outline of that from the occlusal or basic view, they are very different in grinding and milling capacity. That depends on the accuracy of the manufacturer. And if you look in the lower range there in pictures, you see even some inaccuracies depending on how it was milled, the precision of milling. And if you go in an upper way in there and you magnify, you see a breakout to the left, or you see something which more is alike like a knife edge to the far right. And that has an influence not only on the technical aspect, so is it luted well and will it stay there, the crown, even on the biological way, if you need to cement, you will have a big cement gap. So your question with your restoration of the molar, I think that's very interesting, and it's important to talk about that.
Peter, can we zoom in there a little bit, because I find that very interesting. Coming back to your idea of having a tie base and then starting with zirconia, lithium disilicate, whatever. What is your take? I mean, because people are discussing also in the literature, how big should the titanium base be and how small should the zirconia be in contact with the soft tissue? So you have a general rule of thumb. So some people say, well, the tie base should be as small as possible and start immediately with the polished zirconia. Or other people say maybe make a 2 millimeter tie base and start later with the zirconia. You understand what I mean?
Absolutely. The dimensions of the tie base are important. First of all, as I said, retention is important. That means the chimney, the part where we put on either the full ceramic crown or just the coping. And see, this is something where we just got new studies out there where we see that, of course, the longer, in the vertical height, the longer the chimney of a tie base is, the better retention we can achieve. And then we are talking about angulation. How much can you be angulated within screw access? So there is no basic rule available right now, but it makes sense that, let's say, the down part of the titanium base in there, the plate, for example, this is rather thin. You said 1 or 2 millimeters, for example. Then you start to put on either your chimney ceramic zirconia or lithium disilicate coping on it, or the full ceramic monolithic crown. But the
for you, it would be fine if you start quite early with the zirconia and
yes.
But what do you say about other people saying, I mean, you need titanium in the adjacent area of the connection of the implant because it seems to be better to the soft tissue? Is there any scientific hint for that?
I think scientific data are not available enough for that really to conclusive summary to say that we need more weight for titanium and less for zirconia.
Yes.
What we know is that both materials are as biocompatible or non-biocompatible. So for me, there's no difference yet. And there's no data available showing the one or the other is really better. So it depends on each study. There are single studies available, but some of them are contradictory.
So sorry for picking in that topic because I like it very much because so how would you decide or are you just doing it like you told me, very small plate of titanium and then start with the ceramics? That's actually what I do.
I would rather say, just not to forget the emergence profile. How do you do it? Concave, convex, and there's enough studies available that you do it in a concave way, that you have a running room in the soft tissue. And I think the design of the outline out of the soft tissue is, for me, much more of importance than 1 or more millimeters more zirconia or titanium.
Very good statement. Thanks, Peter.
So that means if we have these kind of abutments, and you see that, again, this happens to be a zirconia sleeve or mesostructure on a titanium base. What is important is that we, on one stage, we would love to have aesthetically sufficient restorations. On the other side, they have to be stable for a long time. And this has not been believed and trusted in for a long time. When we started with tie-based abutments, you see basic studies we have published in 2013. This is more than 10 years. Most of the people said we should watch out because it's not retentive enough. Then the question came up from a biological, from a periodontal point of view. If you create an artificial gap within the abutment, which is close to the crestal bone and the soft tissue, I mean, this could be hazardous. This could be really a trap for bacteria, for example. And we did show, this is a crosscut, this is microscopy, where you see in red, we just underlined that this is the luting gap between a zirconia coping mesostructure and a tie base. And we could show that in average, if you do it correctly, this is 30 microns. 30 microns today is a very precise luting gap. And there's even now clinical data and long-term clinical data available where there is no difference between a 2-piece hybrid abutment, tie base abutment, or a 1-piece titanium abutment. You can use it safely. If you don't like them, there are other options available. And that brings us to 1-piece CAD/CAM abutment. The option of a 1-piece zirconia abutment, CAD/CAM derived like to the far right, is something we do not do anymore because just strong material, as I said, we are, frightened just of the fretting, the grinding in the implant abutment connection. Then having titanium in the posterior regions for implant restoration, this is a safe thing, no doubt about that. For the anterior regions, there are more and more discussions because of the color shift, the discoloration of the soft tissue. And in the middle, we have again the titanium nitride. This is a very interesting material because it is still a one-piece titanium abutment with a very thin layer of titanium nitride. Either it is gold hue or it can be pink, as I said. And there is, much data available there for a long time. You see the publication here from the Italian group that this is a very biocompatible abutment surface, which has very little bacteria and plaque accumulation, better than pure titanium. And what I like is this is a one-piece thing, but the question was, is it, the right material and abutment for an aesthetic region, for anterior, as we said. And what we have shown is because of the gold hue, it can be used in some of the instances, but again, now the combination of material, you can use a one-piece gold hue abutment like this one here, but you cannot use any more very translucent lithium disilicate. So EMAX, for example, lithium disilicate crowns, and this combination cannot be used. You would rather need then a coping of zirconia covering the gold and having then veneered, then you would have a nice crown, as you see, but you have beautiful soft tissue outcome, no discoloration in the mucosal part, and that's the combination that makes it more interesting. You see it's getting more complex if you look for other options, and they are available.
Peter, is there any chance to go fully screw retained with titanium nitride, or would you always then go cemented?
It is possible to use these gold hue or titanium nitride covered abutments, and you glue extraorally in the laboratory,
Okay.
and then you have an angulated screw access, because now most major manufacturers deliver angulated screw access. And this makes it even easier because, again, we all like if they are retrievable in case we need access to the implant, or we have to redo the case. And screw loosening is an issue as well.
Got it.
So this is the part of obvious aesthetic concern for single or even multiple implants close to each other in the aesthetic region. But what I would like to allude, and not that we do not forget, we do even see patients who are edentulous. They receive implants, multiple implants. And we have different options available, as you can see here, between a fixed restoration on these and removable restoration. And these patients are, as much as those I have shown already, concerned about aesthetics. So aesthetics is not just an issue for a one-piece restoration in the anterior. So in Northern Europe and specifically in Germany, we are all trained with good lab technicians who are able to produce a double crown or telescopic restorations. This is something where we need very much good trained lab technicians in there. And what we like to work with, and therefore I have included that into that presentation, again, we see tie-base abutments here. This happens to be zirconia sleeves or zirconia mesostructures, luted extraorally to tie bases. And then we use these abutments in there and we do as a double crown galvano plating on that. So we have double crown. First is the tie base abutment, and then we have a double crown in here. Of course, we are taking advantage today of the CAD/CAM design and later on CAD/CAM manufacturing that makes it easier and more predictable. And doing that with the electro gold plating, we have two materials available which do have really no stops. So it is just held by capillary forces. Even our superstructures, which you see here in metal, are selected laser melting. So we do not, or we try not to cast anymore. Casting is something which we know in implant prosthodontics is always linked to inaccuracies. We would like to get away from that. So having these kind of options, we intraorally bring in, we insert the tie base abutments. We try in the gold plate galvano, and then we intraorally lute them with a framework. For that, because everything stays in the mouth, we have so-called travel or temporary dentures. That means once we have screwed in the abutments, and we can combine it with natural teeth, so this is no problem. Once we have inserted that together, now we lute intraorally the galvanos, and very interestingly enough, is it still necessary to know how to make analog impressions? Oh yes, an over-impression here with a polyether material, soft reline the travel denture, the temporary denture, and then we have results which are very predictable. That means you as a surgeon and periodontist, Stefan, you know, and everybody else knows very well, if there are defects in the bone and therefore defects in the soft tissue, where if you have very demanding patients, sometimes it's not easy to achieve a predictable nice outcome. If you have cavadenture technique and, you know, these kind of restorations here, and I go back to that just to show, this is Carsten Fischer, the lab technician I'm working with. This is as, you know, individual and aesthetic as possible. And if you have critical patients, maybe this is an alternative and an option. And sometimes this is forgiven. You know, this is sometimes, some people, they say implant restorations or implant dentistry is always linked to fixed restoration. And from a hygiene point of view and from a predictable aesthetic point of view, this is an alternative. But this goes, you know, if people are asking, so are you doing always removable in implant cases? No. But
Peter, can we go back to that case for one more time? So that was a galvano, a telescopic restoration. By the way, if you have Carsten as a lab technician on your side, you must be more than happy. Congratulations to Carsten for that work. Would a zirconia telescopic restoration, would that be an alternative for you? And why didn't you do it?
You mean zirconia as the double?
Yes.
Because, you know, it's really the choice of material here that the galvano will be plated directly on the abutment. So you have the absolute fit. You have, you know, there is no other material besides zirconia and galvano which fits so passively together so far. Not even non-precious alloy, because we started with non-precious alloy for financial reasons for the patient. We do not know any other combination of material. And zirconia is not as successful as zirconia and gold plating. And there are a couple of clinical long-term outcomes, specifically from the University of Frankfurt.
Because of grinding, or what is the issue?
You know, the non-passive seating of the double crown on the primary crown or abutment is a major problem. This is the basic problem in clinical work, because patients cannot remove the restoration. And if you start polishing from the inside of the double crown, you're lost forever, because sometimes it is too loose. And therefore, double crown technique is not very favorable among clinicians because it's not easy. But I think with this material combination, it can be easy. The only disadvantage and drawback is it is quite cost intensive, and not every patient can afford that. That's the disadvantage. But clinically, we do that for more than 15 years. And again, the scientific data are very promising there. And you can go palatal free if you want there. If you 4 implants, of course, you cover the palatal to get some more support. And you see from an aesthetic point of view, you can really have acceptable designs.
Acceptable is nice.
Yeah, we have to be very careful, because individual interpretation, what is beautiful or what is not beautiful.
No, I think we're all clear. I mean, this is beautiful work.
So from a biological and, let's say, medical point of view, when do we go for fixed restoration, multiple implant restoration in the maxilla or mandible, and when do we go rather to removable? We all know if our patients are showing up to our offices and clinics and they have severe bone loss and soft tissue loss in there, you know, this vertical difference here between the green and the red line has to be filled up by restorative material. And if this gap, this vertical distance in here, this is called the composite or ceramic defect in there, if you see to the upper there, if there's minor composited defect, we go for fixed restoration because there is less material we have to build up. In contrast to the lower line, you see considerable composite defect. If there is a very high vertical distance, we would rather go for a removable restoration according and together with the hygiene possibilities, because fixed restorations for the patient, that's not available, or it's not the right choice for all of our patients, because they have lost their teeth because of, let's say, inferior hygiene. So what we like to do, of course, and what we are aiming, and there's a tendency of fixed restorations, that we are taking advantage of CAD/CAM generated restorations. Like, for example, here, this is, it can be titanium, but this is not titanium. This is non-precious alloy, and they're, milled from one block because there's no casting involved anymore, as I said. And then one option is really to ceramically veneer that. Again, we as restorative doctors, we rely very much on the competence of our lab technicians in there. And this happens to be a case where we still used analog impressions. So a closed analog impression, there were still some natural teeth available in there going to be extracted. We did analog splinting, and I just included that into the presentation to show that even if we went for different stages in the analog way, we put a lot of work and effort to do it as most accurately as possible. So we took twice an impression just to deliver a master cast where the dental technician was able to have a screw retained restoration, which was, there is metal, cobalt chrome, and it's ceramically veneered, and then we could screw retain it. So we use CAD/CAM design in the laboratory and there, and some of them even in the work of the office. But if we look at these kind of restorations, and I think all of us have patients where we say, yes, we do have patients who are able to clean that properly. All of them are coming into the office and in the clinic for regular cleanup, but some of the patients are not able to, clean that properly, and therefore we might consider removable. But to tell you the thing, when we now go digitally, and most of us are now in the transition of going in intraoral scanning from the analog impression to the digital impression, and what are the influencing parameters? And this is one of the most challenging things for me, to have a full arch restoration where I'm aiming to have a one piece, either zirconia restoration or metal restoration, because we are able to scan. This is not the problem anymore. And if we have such a scan, we can, send it, as you all know, to our lab technicians around the world. But to deliver a fitting one piece, full ceramic or cobalt chrome restoration on that, this is quite a challenge. And I hope I'm not the only one who has that problem, because as you see, the laboratory work is very meticulous in here. We have, for example, a one-piece zirconia bridge, cross arch. Everything has to be nicely, and it has to be accurate. And if you look in the combination, there have been two older implants in the anterior, and there have been new ones in the posterior. So you mix two different implant abutment connections in there, which might has an influence. And then you put tie-base abutments. See, Stefan, again, tie-base abutments. And then we try in the ceramic one piece or even splinted bridges. They do not fit. They do absolutely not fit. We know that problem from the analog way, where we did double check and double impression taking. But here, if people are talking about we scan, that means obviously we have to rethink, and what are the influencing parameters? We took an analog impression with silicon material, and the first bridge we tried in on that scan on the model there on the master cast, and we have seen it did not fit. And wow. we did not even know the reason. This is the most frustrating part of that, because we, as I said, we put a lot of interesting and work on there. I'm happy just to summarize that we did a systematic review on the influencing parameters. And I was surprised, this just came out last week, I was surprised how many influencing parameters we have to consider. And one major point is the design and the material of the implant scan body. We all are familiar with our implant scan bodies because most of them are delivered by the manufacturer. There are some copies in there, but it seems like that we need a more comprehensive scan body. So far, the combination of a metal base and maybe an acrylic or PEEK superstructure would be nice, but cross-arch scanning is a challenge today, for me at least. And maybe we should rethink about the design and the material of scan abutments. And we are participating in a clinical study where we are using these kind of abutments. So you see these scan bodies in here. You can individually choose them, that you try to have the gap between the implants as small as possible. If you scan over, there are small gaps in there, and you can individualize them on multi-base abutments in here. And this is hopefully something where we have these kind of restoration. And this happens to be a screw-retained temporary acrylic bridge, which then intraorally fit well, either in a combination where you have a good scan in the beginning, or you intraorally lute them to some of the metallic bases in there. And there, so far, it seems to be promising to overcome that challenge. But we did not even know that this challenge is accurate.
So Peter, let's make it clear. What would you do today in a full arch case? Because I've been talking with a lot of top-notch digital experts and lecturing all around the world for digital dentistry. And when I then ask them, what are you doing in the aesthetic zone? And what are you doing in full arch case? They say, Stefan, I do an impression. So what do you do?
So one way would be, to be open. One way, you first take a scan where you have the production of the abutment. Then you have the try-in of the abutments, and you take, as you just said, an analog over impression and hope that that impression is as accurate as you would like to.
But if you want to do it screw retained in multiple segments?
Yeah, you have to intraorally lute them together, for example, which we know from implant dentistry for a long time. There's a lot of analog work. What I'm concerned is the combination. Sometimes, we start with digital, then we go analog, and then we go digital, and then analog again. I think it doesn't make sense, first of all, and I'm afraid of that we buy our own complications for that. Yeah. So we bring
learning curve.
Complications in.
The learning curve.
Yeah. Therefore, having a restoration, which, first the implant scan body, then having the bridge work, for example, first, and then try it to intraorally lute that, because we are very well trained in intraorally luting with the double crown technique, and then passively having seeded that, and then it can be veneered, or you just put a cover on top of that. So there's still a combination. And I don't know, for me, there is not the one right answer. And as you see, we're just working on new options. So this is still an interesting field, but we have to be all honest to each other. It's not easy.
Peter, having my own office, I mean, it would be great to have, just also for your team, to have one streamlined flowchart. You get my point? Not having both of these things
Absolutely.
At the same time.
See, the thing is, it would be nice to have a one solution treatment plan for full arch restoration. From a functional point of view, placing the implants and having a so-so seating restoration, we see that everywhere. Everybody stays, it's a passively seated restoration. I'm just, be here and tell you, not in all of my cases this is possible. Yeah. We are still looking for options.
Okay.
So, and that actually brings me to, implant prosto without complication is desirable. I understand fully what you and we all need, but it's not realistic right now. We see complications, and we have to overcome that by just, trying things and work on that, even in a digital workflow. Just being digital, CAD/CAM, is not the warranty of being more precise. The abutment selection, and I hope I brought that over, should be patient-specific. We have a variety of material options and design options, and we should consider them for each and every patient. For the single implants, and short span, so some of the implants together, close together, the intraoral scanning shows sufficient accuracy in capturing the implant position. But if we are going, as we just saw at the end, if we are trying to capture full arches with multiple implants, we need further investigation and to avoid any possible deviations. And this is actually what you're just asking for. So we are all working on that and try to find the one way where we are successful.
Peter, that was amazing. Thank you. I learned so much. It was a great presentation. Thank you very much. People are applauding to your lecture. People saying, great speaker. Congratulations, says Bonato. Arndt Happe saying, great lecture, Peter. Hello, Arndt. Thanks for watching. Amazing work. And on also putting it together with your scientific work, chapeau. It is great to have you and great to have your knowledge. Peter, there are some questions. I, of course, have questions. Let's see how many we will get. First question would be, people are talking so much about zirconia versus lithium disilicate, saying lithium disilicate is better in the aesthetic zone, zirconia is stronger. What is your take? What should I use?
As far as I'm concerned, there seems to be enough data to state that the retention of lithium disilicate to tie bases, for example, is superior compared to zirconia. If we are talking about lithium disilicate as a material for the ceramic crown and the translucency, even again, this material can be, be more superior with regards to aesthetics. So I would summarize that as something, it depends on the group who is working with the material. So if you feel fine with zirconia alluding to titanium, I have full ceramic cutback crowns being veneered in the non-functional area, go ahead, because if you have success, this is fine, this is good. If you would like to work on the high end, really using high transparency, translucency, wonderful crowns, you have to watch out what kind of substructure, what is the abutment, what is the combination in there. But there are some advantages of lithium disilicate, but you cannot say the one is good and the other one is not. So work in your group with a material you would like, you see the best results.
Yeah, good statement. I think that's very important. One more question which came up is you talked about a lot about veneering of your superstructure, being it zirconia or whatever. Do you see chipping, and is it an issue for you in particular in full arch cases? Where there seems to be the sensibility a little less than when our teeth are involved, and what do you do against it?
Absolutely. Of course, I do see chipping. I have seen more chipping when we have used metal structures, so bridges, and have manually ceramically veneered them in the laboratory. Because you need absolutely good occlusion, and even then, you just said, sometimes we see it as well. Therefore, in single restorations in the molar region, we go monolithic, because all of us, we have seen chipping and ceramic fractures in there. When we now go for a full ceramic restoration, being alluded, for example, on multi-base abutments, and we are able just to ceramically veneer the non-functional buccal or labial parameters, we might see less, and this is where we are going now.
Like a cutback with just a window of the aesthetic buccal corridor.
Yes. Yes.
So all the functional points, like the static and the functional occlusion, are on monolithic material.
Exactly. So that combination probably, but there we need a monolithic bridge which fits accurately on the abutments and within the implants. And this is what we are working right now. But this combination.
Do you see any monolithic material which is already there in the top-notch aesthetic zone? Just monolithic? Is there a material already there, or do you think not completely?
There's promising material out there, the new multi-layered ceramic blanks, for example, which can be milled, where virtually you put your bridge, for example, according to the layer of the given color shades in there. There are some zirconia material which seems to be very promising. We checked that out, but it's too early really to say this one is better, because if you look at the ceramics, specifically zirconia, the zirconia where we have scientific data available, we are not using anymore. And those we are using today, all of us, there is no long-term data. So we are really in a challenge there. We still have to wait.
Peter, that was amazing. And you know, we're Germans. We have to start on time and we also have to stop on time. But actually, I have one more question, and this comes from me, and this is allowed. How do you treat your restorations before inserting, concerning cleaning? Are you steam cleaning them, going with chlorhexidine? People saying we shouldn't do that anymore. So just your clinical procedure of cleaning your abutments before insertion.
So that's a very nice question. I know that you know that we have done some studies on how to clean. Sterilization is possible even for tie-based abutments, but it's very time-consuming and I think not realistic. So we are aiming for an ultrasonically cleaning, a 3-bath each 5 minutes. You have a disinfection material and then you clean it. And we have shown in multiple studies in there, this is a very efficient and not too time-consuming procedure to clean all your abutments and all superstructures. Thank you for asking.
I know, because I like that procedure very much, because no one knew anything. People are going steam cleaning and whatever, and I like that procedure. And then we have argon plasma cleaning, which doesn't make any sense, right? Peter, it was amazing. Yeah. Thank you so much for being with us. This already time has flown. People are greeting you from all around the world. I think you can later go into the YouTube and look for the comments. Great lecture, very helpful, clear lecture. Greetings from Argentina, greetings from Estonia. So you are already world famous. And just to know, we just have the subscriber number 10,000 for the EAO channel. So which is nice. So just 2 more things. People subscribe to the EAO channel. Have a look at our Milan Congress, which will be in September this year. You can still put in abstract. You see how nice it is to work scientifically. Peter has shown that nicely to connect that with your clinical work. So submit your abstract. I guess, Peter, you have already also been in your very early times, be it at an EAO presenting an abstract, right? I guess.
Sure. Yes. Yeah. Always. And it's fun. I hope I see you everybody then in Milano.
Wonderful. Thanks everyone.
Okay. Thank you very much, everybody. Have a good night.
Have a good night. Ciao, Peter. Thank you very much, and see you around. Ciao, ciao.
Thank you, Stefan.
Ciao.
Bye-bye. Tschüss.